love it, Carolyn. Thanks for coming. I'm very happy to send a welcome to Carolyn Lebeis, who is coming to us from Mercy ENT, along with some of her colleagues here today. So Carolyn is a speech therapist, and she completed her master's in speech and language pathology at Boston University, and also completed a clinical fellowship at Lebeis Hospital, where she worked as a clinician for a few years after that, until she has come here to join the team. And Carolyn has the pleasure of speaking on a few occasions about vocal cord dysfunction and the differential of vocal cord dysfunction, because this is obviously a challenging entity to diagnose. And I was really excited that she was excited to come and talk to us about it today and help us to try to get a handle on it and make the diagnosis more accurately. So take it away. Thank you.
Great. Thank you much for the introduction and for having me today. So, as Dr. Clayman said, I'm a speech pathologist. I work at Mercy ENT Associates and was at Leahy for 7 years prior to moving to Maine. My interests in speech pathology are in diagnostics and treatment of voice and swallowing disorders, with a particular interest in head and neck cancer, laryngectomy, and tracheoesophageal prosthesis rehabilitation. In terms of this talk, Dr. Clayman and I have been sharing a lot of patients, along with other providers in the area, with a diagnosis called vocal cord dysfunction, which in the speech pathology world we like to call paradoxical vocal fold motion or movement. That's really what we would call it. So when I first moved to Maine, I was like vocal dysfunction, what is that? I don't know what this is. And there are so many people diagnosed with it, mostly females, and we'll talk more about that later in the presentation. But it was perplexing to me the wide amount of diagnoses I was seeing an outpatient clinician with this diagnosis. So just a general introduction of the flow of the talk. Please let me know if you have questions throughout. I'm happy to answer them. So vocal cord dysfunction, or as I said, I like to call it paradoxical vocal fold motion, is a condition where the larynx exhibits vocal cord closure or adduction during inhalation. So that means the vocal cords come together when they're supposed to be opening when the patient breathes. Multiple terms for this condition have floated around over the past 100 plus years: functional airway obstruction, psychogenic stridor, spasmodic croup, and there are sort of two variants based on the physiology. So that's adduction of the true vocal folds, we have two of them, and the ventricular vocal folds, also two of them, throughout the breathing cycle, both inhale and exhale. Another variant is adduction, again, coming together of the vocal cords during inspiration with slight adduction, so moving away from each other on exhale. History, vocal cord dysfunction or paradoxical vocal fold motion was first described in 1842 as a condition called laryngeal spasms affecting hysterical females. How lovely. Munchausen, Stridor, so these would be women who would come in uncontrollably crying, and that was sort of the reason for the label. Later defined a few years later as spasm of laryngeal muscles during great distress, which I think actually is sort of characteristic of how it can present today. Epidemiology. This is where we struggle a little bit in the clinical field, because prevalence is largely unknown at this point, due to limited data to quantify the diagnosis and the uniformity in how we diagnose these patients. So paradoxical vocal fold motion has been reported to occur more often in adults than children, more often in females than males, particularly females in their 20s and 30s. Rates in women in healthcare professions, athletes, those in the military, those who are overweight, struggle with stress and anxiety, or have history of childhood abuse or psychiatric disturbance. Etiology, similar to epidemiology, no single cause has been established in the research, but there's very little research out there definitively about this condition. A lot of review of literature to look at some of the etiologic causes or the causes of this condition, and there's a lot of overlap. So I've broken down into three different subtypes. Neurogenic, or the pharmacologic etiology. So that's just some examples: respiratory type, adductor laryngeal dystonia, again, hyperclosure of the vocal cords during the inspiration when they should be opening. Typically, these patients respond to Botox. Those patients with brainstem abnormalities, more often in children than adults, you see some neurologic conditions there. Also, drug-induced laryngeal dystonic reactions. Could be from neuroleptic drugs, anesthetics. So some patients will have some stridor along with coming off of those medications, and that present as paradoxical vocal fold motion. Mostly is the etiology of laryngeal hyperresponsiveness. So in the world of speech pathology, we're seeing a lot more patients with that irritable larynx syndrome, that hyper-responsive nature of the larynx. And a great quote from one of my favorite seminal articles about paradoxical vocal fold by Patel and colleagues that says, the rich presence of sensor receptors in the larynx. The role of the larynx to protect the lungs and trachea from noxious irritants is local that the larynx is hyperresponsive to any stimuli that can result in adduction, again, or closure of the vocal folds. But pathophysiology is unknown. So when we think of laryngeal hyperresponsiveness, we think of the triggers: upper respiratory viral infections, allergies, exposure to chemicals, flames, smoke, odors, exercise-induced bronchospasm, respiratory irritants, gastroesophageal reflux or laryngopharyngeal reflux, which we've been able to differentiate in the literature becomes the most common cause of paradoxical vocal fold motion, or that sudden choking that people experience, because it's direct contact with the gastric fluids to the laryngeal structures. These triggers cause the reflexive adduction of the vocal cords, which develops into an inappropriate learned behavior, which is sort of what the patients that I see are coming in with. They've been doing this for a long time. And then psychogenic or psychiatric etiology, so patients with conversion disorders, significant stress, those struggling with malingering, and then other social stress in athletes, people with sexual abuse, depression, anxiety, stress, fictitious illness. There was a study in the early 90s about psychiatric diagnosis, and 73% of those patients had reported symptoms of paradoxical vocal fold motion. 30% of them had history of sexual, physical, or emotional abuse. That doesn't mean that all PVFM patients have experienced those, but it's something to consider when we do our intakes on our patients. When we talk about symptomatology and clinical presentation, we want to think about where are we going to see these people. Patients present at various care facilities, so either at their practitioner or primary care provider, and specialists, pulmonologists, allergists, immunologists, otolaryngologists, gastroenterologists, so in the emergency department. So when we talk about paradoxical vocal fold motion, again, you'll hear me say this over again, it's that adduction of the vocal cords inappropriately when they should be opening. It's characterized by symptoms of shortness of breath, ability to breathe during inspiration, or patients typically say, I can't get enough air in, working. Patients may wheeze, have stridor, cough, voice changes, tightness in their chest or their neck, some thrilling sensation, or the sensation that their throat is physically closing. The gold way to diagnose true paradoxical vocal fold motion is through flex endoscopy or rigid laryngoscopy. It typically follows a challenge, some sort of exercise challenge, whether making these patients run or breathing in some sort of noxious stimuli. So if you would, I just want to show just a quick clip of paradoxical vocal motion that I found on a lovely YouTube, but I've used it in the past in patients. And this comes from Dr. Chang at the Faulkner.
When the vocal cords come together when the person is trying to breathe, recall that the vocal cords are supposed to move apart with breathing.
See, they're coming together, and he has very visible. You can stop it there, Evan. Thanks so much. So description is sometimes helpful, although you may not be seeing these patients endoscopically. Well, Dr. Lease might be seeing these patients endoscopically, but endoscopic exam really is a true way to say, okay, that patient actually has PVFM. I'll talk about the downsides of that exam a little bit later. So again, diagnosis can be difficult because this condition is episodic. Sometimes the patients who come into your clinic are having an acute attack at that moment. So having them replicate the symptoms is really difficult. That primary symptom of dyspnea or upper airway constriction is often mistaken for asthma, which I'm sort of going to debunk a bit in this talk, because teasing up asthma and vocal cord dysfunction is a lot of what we have to do in the field. There are several studies that report the coexistence of asthma and PVFM, which makes it even more challenging. Which part is the asthma and which part is the vocal cord dysfunction? And it remains unclear. Also can't rule out other diagnoses, lateral vocal fold paralysis, other conditions affecting the larynx, neoplasm, or dystonia. Again, a great reason for an endoscopic exam and someone you're concerned about, because you don't miss any of those other things. So my favorite is PFM and asthma. I put together this little grid that I gave to my graduate students at Leahy as a quick, down dirty sheet. Does this patient have asthma? Not that we as speech pathologists are diagnosing asthma, because we're not, but what are the differences here? So asthma, you know, the bronchial tubes tighten, making breathing difficult. With PVFM, it's the vocal cords adduct or constrict, also making breathing difficult. That's hard when a patient comes in and saying, I'm having breathing difficulty. On asthma, though, PVFM is not an allergic reaction starting in the immune system. So I won't necessarily go through all the specifics here. Oh, I was pointing to something, Evan, sorry. I'll go through all the specifics here, but then you see paradoxical vocal fold motion, difficulty to get a breath in with tightness in the throat on inhalation with no help from inhalers or other medications. Typically stops right after activity, and O2 sats are always normal. So in differential diagnosis, as providers and as speech pathologists, these are all important aspects of a clinical exam and case history. So clinical cues, patients have increased respiratory rate. They may localize the symptoms to the larynx and have poor response to inhalers. We always want to ask about triggers. What brings this on? And a list of some of the triggers that the patient may describe. On physical exam, asking the patient to pant. Sometimes that can cause the symptoms to come back. Asking the patient to hold their breath. Again, that may replicate the symptoms. Laryngoscopy, flexible or rigid. I came from a school of flexible laryngoscopy for everything. It was easier, although patients may feel uncomfortable. It was a more functional exam because the patients could talk and sing with a scope in their nose and their throat. With a rigid exam, it's much harder for them to do that because we're yanking on their tongue. So you'll see some of my videos. I do both. The rigid exam is much better, and that's because our resources at my current facility don't allow me to get flexible strobes on everyone. We're in the process of getting all new equipment. So it's critical for laryngoscopic evaluation to be part of the diagnosis. Again, it's that we're looking for is at the adduction of the vocal folds. Classic pattern is 2/3 of the vocal cords closed during inspiration, and there's a little bit of what we call a glottic chink. So what you see when the vocal cords come together is there's a little V at the top. Women typically have this anatomically anyways, but it's a little bit more pronounced in someone with PVFM. And so we can't forget about our respiratory function tests. I would say that a large amount of my referrals for VC or VCD rule out are from people who are going the necessary important respiratory function tests. So what we want to be concerned about or look out for is those patients with no response to bronchodilators, a flat inspiratory flow loop, L ratio of expiratory inspiratory flow, negative methylcholine challenges, normal O2 sats, and normal chest x-rays. I showed this scenario from a speech pathology standpoint, but respiratory function tests are not specific in actually diagnosing a patient with PVFM. It's just, it helps us clinically identify those patients who may, in fact, have it, as well as eliminating asthma. So when we talk about management, as providers, we think about acute or long-term management. So acute management can be patients are hospitalized, they're either intubated or trached. They can have immediate relief from the Helix mask, which is 8% helium, 20% oxygen, which reduces the turbulence in the airway. Positive pressure ventilation and continuous positive airway pressure ventilation allows the airway to open, again, reducing the noise. Anesthesia, benzos, and general reassurance to reduce anxiety. And in very severe cases for acute treatment, sometimes these patients are injected with Botox to help actually relax these structures. The research has shown, the limited research has shown that acute management done in conjunction with speech pathologists provides the best outcome for patients. Again, asthma therapy with bronchodilators, oxygen, corticosteroids have largely been shown ineffective in treatment of patients with PVFM. When we think about treatment, chronic or long-term, it's multidisciplinary, working with multidisciplines to treat this condition. So with the speech pathologist, and then looking at asthma, reflux, allergies, sinusitis, anxiety as contributing factors. So why should we care about this? I was reading this presentation to my husband, and he's like, okay, so this is good, but why do you want the physicians to care about this? And it was a good question he asked me, because it is important, because we find that a lot of our patients are in that category of trying to figure out what the diagnosis is. So in order to decrease misdiagnosis, decrease repeated e-visits, unwarranted trachs, ventilation, steroid prescriptions, bronchodilators, and to reduce overall patient frustration. That's why we care. And also the need to increase the awareness of paradoxical vocal fold motion in our community. And in our community here in Southern Maine, there's a lot of it. A lot of girls from Cape Elizabeth High School and Yarmouth and Falmouth, I see them. They're in my office on the weekly with this type of problem. So it's expanding the resources for SLP treatment, making appropriate referrals, also allowing us as providers to collaborate about these patients. And Dr. Klayman and I do this a lot. So as a speech pathologist, not to get too speechy, I'll talk a little bit about what we do in treatment of your patients. So again, general assessment, we interview the patient. We get sort of down deep there, talking about stressors, social pressures, boyfriend, girlfriend drama, any history of emotional upset, stress. And I'll talk when I show you the case studies why that can sometimes be hard to do in initial interview. Measure their respiratory pressures for their voice, assess their tension at the level of the larynx, which is a lot I do. It's actually massaging and manipulating their throat to feel, is there a musculoskeletal component to this? And the laryngeal exam, which you'll see later in the presentation. In terms of treatment, we talk about direct or indirect treatment models. So the direct model is actually maintaining an adequate airway. So I've listed some, direct treatment examples: relaxation of the musculature, a lot of breathing techniques, typically that focus on nasal inhalation, which allows the vocal cords to open. The best way for the vocal folds to open versus if you take a big breath in your mouth, that can sometimes cause them to close slightly. Resonant voice therapy, which is, again, another gold standard voice therapy treatment, and biofeedback, showing them their scopes and saying, your vocal cords look beautiful, they look normal, I don't see any lumps or bumps or abnormal movement here. And a lot of what I do, and I feel fortunate I'm able to do treatments, so patient education, relaxation, reassurance, and some vocal hygiene recommendations. So just a quick example of a treatment method I use with a lot of these patients, regardless of what their presentation is relaxed throat breathing. So teaching them to relax their mouth as much as possible and engage their diaphragm. Teaching them about diaphragmatic breathing and using a very gentle exhale, which again is a passive force of air moving through the open vocal cords. So the vocal cords aren't coming together when they make the, as if you were making an your vocal cords are coming together here, but they're not, okay? So them a therapeutic protocol to work on at home. Do the breath cycles when you feel normal. So do them when you're having an attack. So the theme is there's not a ton of research, but a great study that came out in 2015 was a literature review of all of the articles published on the evidence or efficacy of speech pathology involvement with these patients. We don't get into the specifics, but 65 articles that were published were examined. Only 2 of the publications met controlled research design criterion, which is hard. Project numbers are small, research articles are small, then demonstrates the emerging nature of the evidence regarding the efficacy of our treatment. Futures are doing research on it, and there's, again, that lack of understanding of the clinical presentation, which makes it hard to diagnose and treat. The efficacy of speech pathology treatment, there have been really 2 studies in the field that have shown good outcomes based on an actual research design. The first one is for a patient, an 18-year-old patient with exercise-induced paradoxical vocal fold motion, and what Mather Schmidt and her colleague used was an inspiratory muscle training tool to increase inspiratory muscle strength. And they used this with a single subject who was a runner. And over a 5-week period, she showed complete reduction in her PVFM symptoms. So before I left Leahy, I just gotten IRB approval to start using an inspiratory muscle tool for our patients, and then I left. So I don't know exactly how it's going. Sometimes with research, things stall. And patients with chronic cough, paradoxical vocal fold motion, we see that in a lot of our males, our older females with that cough for 10+ years. And the Vertigan and her research team used more of a traditional approach of education, hygiene, counseling, and strategies to control the cough. But regardless of the study specifics, all of the studies worked on breathing either at the vocal fold level or at the level of inspiratory muscles. So fun stuff, case studies. So, questions about anything so far? Sure.
I have a patient who doesn't have breathing issues, but she was diagnosed with spasmodic dysphonia.
Yeah.
Variant of this?
It's not. No, it's not a variant of it. It's a laryngeal dystonia. And so, and Botox is the gold standard treatment for spasmodic dysphonia, but it's not a variant of, it's not the same thing, but it can be confusing. Yeah. I like dysphonia patients. If she needs me, send her to me. We don't see them very often. They're also hard to diagnose. I saw a ton when I was there too. So studies. So my first case was referred to me by both a primary care provider and an orthopedic surgeon, actually, with a diagnosis. You'll see the ICD-10 code, other forms of dyspnea, which was sweet. No evidence of exercise-induced bronchospasm with spirometry, pre and post-exercise, no response to albuterol inhaler. And he said, Carolyn, please evaluate for VCD. I'm happy to do that. That's fine with me. That's what I want to do. So present illness on this patient, 29-year-old female with breathing difficulty when started training for a half marathon. So her complaint breathing during inspiration or this heavy breathing that would sometimes start that first minute she started running and could last 5 minutes or the entirety of the run. She had no effect from albuterol inhalers, no cognitive dysphagia, swallowing difficulty, or vocal hoarseness. But she has significant outside stressors. She's in a rigorous hybrid online and then in-person speech pathology program at NYU. She's really physically active and she's planning a wedding. Past history, anxiety and bipolar disorder. Again, I kind of talked a little bit about her social history. She's on a few medications to control some of her underlying diagnoses. She said she takes Ambien and clonazepam infrequently, but she's taken the clonazepam during these attacks, and she's felt relief of her symptoms. So, again, coming speech pathologist to a speech pathologist, we could talk about the nitty-gritty of a voice evaluation. I won't totally bore you with this part, but when she came into my office, I did a voice evaluation, which is just looking at objective measures when she's voicing, measuring her respiratory function, which correlates with her voicing. So having her sustain sounds like and holding it as long as she can until she run out of air. A sound, again, the air passing through open vocal cords, or which is a voice sound, and the vocal cords are coming together. Her was largely normal in regards to respiratory function. When I went into the massage portion, I really did get into the laryngeal musculature and the paralaryngeal spaces, so underneath her chin, the suprahyoid, at the level of the larynx, the thyrohyoid ligament, which we find mostly is restricted and tender in patients with voice problems, and the cricothyroid visor, which controls her pitch. I also examine her accessory muscles, the sternocleidomastoids, the scalenes, to do a full assessment. She definitely had moderate restrictions in some of these categories, and she was like, oh, that's what I feel, okay? And you can kind of, I'm gonna press on my thyrohyoid ligament, and you can hear what happens to my voice. So continue talking to you. And so you can restriction there, or any asymmetry may cause an issue. So the procedure, she came in her athleisure, as I call it, and it was, I was like, you're gonna run. And I was like, you're gonna run the back bay. She was like, seriously? Yes. So she was like, okay, I'm gonna leave my stuff here and I'm gonna run. I was like, okay, run for 15 minutes, then come in and I'm gonna scope you. So what I'll show you is the flexible laryngoscopy on her without stroboscopy, because our flexible scope doesn't do it, but it soon will. It's a bit of a grainy view, but you'll be able to see that. And then I hauled in my colleague, Dr. Kevin Burke, and I was like, Kevin, let's rigid her, and he has the best rigid technique. I flexed all my patients in Boston. We never rigid, so my rigid skills aren't on par with his, so we do them together sometimes. So let's show the videos for AD. Do AD flex. Yep. You can. Louder goes. This pop. Okay, that's not the greatest view, but I wanted to watch it. Her vocal cords to come together, and they open. Completely symmetric, completely normal, absolutely timed, zero problems here. You get a better. She's trying to tire out a little bit, but it was still normal, even though and she's panting. She was sweating profusely, the poor girl. Pharyngeal constriction was beautiful. She had cobblestoning of her posterior pharynx, but again, that's large normal. Good closure, and you'll see better closure on the rigid exam, which we can skip to now. Thanks, Evan. Yep. this clears in a minute. So with stroboscopy, using the strobe light, you can see the mucosal wave of the vocal cords. You see them symmetrically coming together. You see the tissue. You see the scant secretions. Beautiful, absolutely beautiful exam. No bumps, asymmetry. So what is it? Well, her skull is normal, okay? Her evaluation in terms of massage was abnormal. We didn't catch PVFM on this scope, but we sometimes don't. A lot of times we don't. What does that mean? Well, it means that on today's exam, she did not have paradoxical vocal fold motion. Do I think she has it? I don't. But she has episodic episodes when she, excuse me, not episodic episodes. She could have episodes when she's running. But what I suspect in her is that she actually has muscle tension dysphonia, a variant of a voice disorder based on muscle tension at the level of larynx. So I hypothesize that when she's running, she's holding tightness in her larynx as her breathing is changing. That's causing those muscles to tighten. Base restriction that I felt to palpation. And she has a lot of lifestyle stressors, so that's a component too. Any questions?
You treated her with relaxation techniques?
Yeah, I treated her with relaxation techniques through nasal inhalation, mostly focused on massage for her, teaching her how to massage her own laryngeal structures. And that gives that power that you can control what happens at the level of your larynx. You can control your breathing. Called me 2 weeks after this, and she was like, I haven't had a symptom, and I've run every single day. And I exercises 3 times a day. She's a highly motivated individual, and I check in on her intermittently, and she's been doing great. Our plan was direct voice therapy. As of now, I'm available to her when she needs me. Case 2. This young lady was referred by an otolaryngologist in the community, actually with a diagnosis of vocal cord dysfunction, and I was like, I don't know about this. We'll see. 17-year-old female with onset of choking sensation post-Bell's palsy in 2013. I had very few medical records. She's a refugee from Syria. She had recently moved from Texas. She came in to be evaluated with her mother and an Arabic interpreter. Lovely people, but I didn't have a ton of information, and it was a long evaluation. My graduate student Zoe was with me for it, which was great. She had this abrupt sound, which I can't replicate. I'm going to show you what it is. It sort of sounds like a hiccup, and she was able to do it on command. And she said that this would happen mostly while watching TV, so totally randomly, but we sort of got into it as much as we could. It happened during gym class, and she was, will you write me a note so I don't have to run in gym? Will you write a note that I don't have to do gym? So we'll talk about that later. But that sensation of tight breathing, no swallowing problems, no reported voice issues, no reported outside stressors, but I could sense something. There was something in the room. But you don't get to that in your first evaluation. That's when you bring the patient back and sort of try to get into anything else going on in your life that may be contributing to this. Again, medical history, all I know is she had a cranial 7th nerve infection. She was treated with medication. I have no clue what medication, what regimen. It was not in the U.S. Social history, again, primary Arabic speaker, lived with her parents and her 9-year-old brother, and she's a freshman at Deering High School. She was taking no meds. The otolaryngologist was the first person who had seen her, which is actually unusual because it's typically primary care provider, gastroenterologist, pulmonologist, back to the PCP, and maybe to me. But the ETs are first. So similar to the first case, I do a voice evaluation, listen to her voice. Her voice was normal. Normal in quality and resonance. Her breathing function was normal, although it was hard to get a read because she kept laughing. I'd be like, hey, hold as long as you can until you run out of air, and I guess it's kind of funny. She's hysterical. I couldn't get her to do it, but what I surmise is that her respiratory function is totally normal. Some laryngeal massage, a bit of restriction. She had some pain to palpation, particularly at the level of the thyrohyoid ligament, but no major restriction in other places. So she declared an exercise challenge. So I did make her, and I got rigid laryngoscopy with and without stroboscopy. So the first one I'm going to show you, you're actually going to see her have the event, but it's elicited. I asked her to do it. She didn't spontaneously have it, but you'll see it at the best view I could. Rigid halogen, yep, HS, rigid halogen. Symmetric, so I make the sound. And you completely closing. Rigid exams are hard. Patients are gagging. I'm holding the tongue, and anatomically, her epiglottis is getting in the way. So it's until I have a razor pitch that I can really see. But when she was recreating the sound, they would fully close. Completely plastic PVFM. It wasn't an attack, but it elicited. She was able to do it. So we'll go on. I'm going to advance it if it's possible. It's a long one. Yeah, kind of just away. Middle, yeah, middle. A little bit more. Okay, that's good. Symmetric vocal cord vibration. Completely symmetric. Good mucosal wave. Yes, the posterior glottic chink, which is what we look for, a little bit more pronounced in the first one, which is that V at the top of the vocal cords, that posterior aspect. Might relate with a true PVFM. Perfect. Can I call it PVFM? I actually am borderline calling it PVFM. She's able to elicit it. It looks exact like it, and her laryngeal exam with more of a defined posterior chink makes me think that she does have it. But the lesion, these types of exams, it does happen when these patients are asymptomatic. It's actually hard to see. She was able to recreate the sound. I do suspect episodic PVFM in her. It's hard to know. I do also suspect some muscle tension variant, which may be a correlation of this, could be completely independent. And then I question the role of some outside stressors. So I worked primarily on a sniff technique breathing. So when we have these episodes where she feels that choking, I ask her to force sniff in, which causes the vocal cords to open because her vocal cords are slammed together. I want her to sniff the immediate, as an immediate reaction, and relaxed throat posture breathing. My plan with her is to focus on some laryngeal desensitization to show her her videos and say, okay, this is happening to your vocal cords, but you see we breathe in, they open beautifully. Yes, it does feel like you're choking because your vocal cords close and they're not supposed to. So using some mindfulness and visualization with her. So similarities and differences between the cases. Yes, both females, one diagnosed with breathing difficulty, the other diagnosed with true vocal cord dysfunction, differences in their medical history. The one, she had tried asthma meds with no effect. The other patient had no meds. The first patient ran before her exam. The other patient did not. The first, I think she has PVFM. I think she has more muscle tension dysphonia. The second patient, I think she may have PVFM. Sort of why this matters is they both have benefited from voice therapy. The tension dysphonia, that first patient, and the second patient. So sort of, as you may have gleaned, paradoxical vocal fold motion is a confusing condition to diagnose. Again, it's that inappropriate closure of the vocal cords when the patient is breathing, when they're supposed to be open. That obstruction can be intermittent or continuous, mild or severe. We may always see it. Similar to those with patients with asthma, but we have the part, is it the asthma component or is it true a vocal cord issue? Behavioral therapy is continuously demonstrated in the research and more recent research as being really effective for these cases. So, signs and sounds for referrals. So patients who come into your clinic and complain of breathing difficulty located in the throat, hoarseness or change in vocal quality, dysphagia or swallowing problems, that choking sensation, and they're an otherwise healthy person without neurologic, they didn't have stroke, so you can't chalk their swallowing difficulty up to that, anxiety about their breathing or voicing. And also, I want to see the patients who failed other workups, your allergy workups, asthma, respiratory function tests. And find me if you have these patients. Good to see the Baxter Boulevard practice with Kevin Burke and his crew. You can fax referrals to me. You can email me, which is probably the most effective way because I'm in the office on Mondays, Tuesdays, and Thursdays, and then home with my 2-year-old the other days, which is great. But I'm very responsive to emails. And is it all about any talk about? I have a bunch for you. Thank you for a great audience.
Thank you so much for your help. Appreciate it. Thank you very much. That's good timing, right? I've been here since October. I've been with and Dory, but see it all. Yes. Yeah. Very nice. Yeah. It's a great field thing. Yeah. It's definitely feel like yeah. There's so much you can do. Yeah. And I think too, patients are so obviously, I feel better is usually what I hear. I mean, they do 100% sure. I think people feel better just when you're allowed to talk. Yeah, talk and stuff. And it's a good full hour. It's a full hour. They're exhausting. They're great patients, but they're like, yeah. It's hard. But my pleasure. My pleasure.